I want to introduce our panelists. We have Ed Adamczyk, who is the Chief Pharma Trade Relations Officer at Express Scripts, and he's responsible for all rebate contracting with pharmaceutical manufacturers. We have Jennifer Bryant, who is the Senior Vice President of Policy and Research at the Pharmaceutical Research and Manufacturers of America, known as PhRMA. We have Matt Isles, who is the Executive Vice President of Policy and Regulatory Affairs at America's Health Insurance Plans, or AHIP. We have Lynn Quincy, who's the Director of the Healthcare Value Hub at Consumers Union, and her group at Consumers Union monitors and synthesizes evidence to help consumer advocates work on healthcare cost, quality, and value. And I want to start off the panel inviting the panelists to, with any reactions they have to the Neeraj Sood paper and presentation. In any order.
Since I'm sitting next to him, I'll go first. One clarification in my bio, you may not know this, but Consumers Union is part of Consumer Reports, and I know you've all heard of Consumer Reports. Well, I thought this was a great paper. We have a similar, I think understanding that flow is extremely difficult for all of us. It's very difficult for policymakers who really need to make this work better. We have our own little chart that was somewhat similar. And I think this framing is important. It's really important to understand what's going on at every step in the distribution chain in order to get to better solutions. A few things that I hope perhaps we could inject as part of, as you promote this research effort, would be to maybe provide additional context. So, for example, you anchor it to this IMS number of it's like 325 billion in spending, and IMS actually has a higher number, which is the invoice number, and some people are familiar with that number. So can we help get your readers from this invoice number, which is an even higher drug spending number, down to where you started? We talked a lot about how generic drugs are the majority of prescriptions, but of course the majority of spending is on brand drugs, and a small percentage of a very expensive brand drug may actually provide a bigger incentive to your middle suppliers than a large percentage on a very, very cheap generic, and I think we need to get that in. Also, we are leaving out drugs that are not flowing through the retail setting, but instead flowing through hospitals, where markups are absolutely enormous. And as we'll be talking about, I know what Paul's next question is. We're going to be talking about kind of consumer harm. And so those are some things I'd love, some contextual things that I'd love to see in there.
Great. Good morning, everyone. Thanks for having me here. So just a couple of thoughts. I also thought it was an interesting piece of work, and I would echo Lynn's comments that, there's a large percentage of spending on drugs that is outside the retail chain, and we need to recognize that. Whether you look at the data that Medicare puts out that shows Part B spending versus Part D spending, and we're not seeing a lot of flow through or rebates on that side of the equation. It really also, I think, the bigger issue is around price and competition. What do we see within the marketplace for prescription drugs? Prices are higher and higher. Launch prices continue to rise relative to older therapies. To Lynn's point, that provides additional incentives. When you're looking at a percentage of an ever-increasing price, we use the $100 example because it's simple to illustrate. You should probably add a zero, though, to that. Just to be realistic, when you're looking at like the monthly cost of branded prescription drugs, there aren't that many left that would cost $100 per month, if you're going to be honest. So you really need to look at what the real prices are. Of course, and when you think about the distribution system and potential rebates and, this whole issue about where are rebates occurring and where are they being passed through, I think it's important to recognize that rebates, at least from the health plan perspective, are being used really to reduce premiums for every consumer, right? So we're talking about where rebates might go to a particular individual, and if we're going to channel them there, then we have to expect higher premiums for everyone else. I've cut just a couple of points. And then the final point is, what we really need to look at is how many products are out there on the market that have not had any true competition for a decade plus. You think about some of the largest products on the planet, Humira, Enbrel, tens of billions of dollars per year in sales. And we don't have any meaningful competition out there. And if we were able to get some meaningful biosimilars competition, we might actually be able to talk about things that are more affordable.
I'm tempted to start with some of the things that Matt said, but look, I think it's a healthy conversation for us to have to start looking at in a more sophisticated way at the some of the payment issues in the prescription drug space. So I think it's terrific that we're having the conversation and that we are. Brookings, in a typically thoughtful way, is breaking it up into one conversation about brands and one about generics because they're so different. And I guess that's a mark of getting more serious about trying to solve real problems and not just throw around rhetoric. I would say that I'm not convinced that the treatment of profitability is the right way to think about what we're talking about here for a number of reasons. I think Neeraj did highlight the very huge dissimilarities between industries. But the reality is that the business model of a pharmaceutical industry, which is investing billions of dollars in long shot development of new medicines, you would expect to have much higher profits than an industry which is about moving pallets of medicines, from a warehouse to a pharmacy, right? So that's not a surprise, and I think that really, when people have looked at questions of profitability in the pharmaceutical industry over a long period of time, economists have all suggested that the ways that we account for profitability tend to overstate returns in the pharmaceutical industries. You don't have to take my word for it. You can take CBO's word, Joe Newhouse's word. This is a sort of a standard accounting problem for high R&D and tech-intensive industries. But I think the bigger point is to not be thinking just about profits, but think about what are we getting from the system? How is it working for patients? How is it working for employers? That's what we actually want to achieve, right? And I would argue that the reality is that drug costs are not spiraling out of control. So the system is largely working, but there are clearly high frictional costs that are being pointed to here. And the Sood paper, you're finding results similar in some ways to other studies that are already out there that show that brand manufacturers and generic manufacturers do not represent as much of the spending as most people think. So if you look at the policy debate we're having about prescription drugs, all of the policies are aimed at addressing brand manufacturer spending. But in work that we recently did, which is very comparable here, we found that brands are about 47%. Yeah. So I think it's a healthy thing to begin to broaden the focus, but have a number of questions about the ways, the particular technical results in this paper.
Good morning. Thank you for having me. I thought it was an interesting way of breaking things out and looking at the market, and I think you did a good job depicting it and actually digging through and how you broke out some of the profits, because it was, kind of tough to figure out some of the pieces. I thought was interesting. The one piece I found interesting, you talked about the net price increase. And you talked about earlier in the discussion how prices had increased, but overall the net was down around, I think it was 2.8 in the summary, and which goes along with what a lot of the PBMs had stated in our trend reports recently, or where trends overall are decreasing. So I think ESI reported 3 and 3.5%. CVS was in the same range. Optum was in the same range. So I think while the last slide depicts, or that big schematic depicts lots of moving pieces, it actually drives a lot of competition in the marketplace, which ultimately, with trend or net prices being where they're at, helps to keep premiums to a certain point. And if they weren't, I think premiums may be higher, and we don't know what the market would look like in that. If some of the pieces of that puzzle that you show there aren't there. That's kind of my takeaway from.
Thanks. Anything you want to respond to, Neeraj?
Sure. So thank you all for your comments. I just think Jennifer should have been in the end and Ed would have been in the middle. Then the supply chain would be in order from the consumer to the health plan to the PBM. But, I thank you for your comments. I agree that in the presentation, I didn't talk about invoice prices. And invoice prices are the things that you see in the news. So when you read a newspaper and you say, Hep C drug costs $1,000 a pill, that's the invoice price. And then PBMs come into the picture, and other parties come into the picture, and what the manufacturer is actually getting is much lower than that $1,000 a pill. But how much lower that is, we don't know because these contracts are confidential. I think the picture could be more complicated with the invoice prices, and that's in some sense an important part of the picture. And I think I'll stop there.
And that's, I think, an important point. But you need to have competition within a therapeutic area, right? So the example of Sovaldi, right, when it's out there on the market as the lone therapy, the list price probably is the price, right? It's only when we have competition within therapeutic areas do we actually see prices decline. And that's, I think, an important point to note.
Right, but I would note that net prices for hepatitis C medicines have declined really rapidly, and we do see prices decline. And one of the challenges for patients is that if net prices decline, cost sharing doesn't necessarily follow.
Okay, we're going to have more time to get into this. My second question, and I'll give you the third also. The second question is, I want each panelist, and we'll go in the reverse order this time, what are the most significant issues that we need to address in the distribution chain for brand name drugs? And the final question that we'll get to later is going to be, what are your policy ideas to deal with this? So, Ed, if you could begin.
Sure. Kind of echoing a little bit on Matt's comments, I think one of the biggest challenges is how do we continue to drive competition, because with that, makes people think of different ways to, handle products, maybe more value-based contracting, which comes out of that and showing the value of the products. So ultimately, I think it's some launch prices, which are challenging sometimes for payers and ultimately consumers, but because I've been doing this for quite a while, and I'm a pharmacist by training, so you see the prices change over time. And, a lot of these drugs come out, and they're pretty high priced, and some of the specialty drugs, and I know this isn't on specialties, mostly retail. So to me, that's one of the challenges that we face, and how do we create that competition? Because to me, in the PBM space, it's about driving competition. The more competition we can create, the better it is for ultimately the payer, the consumer, and I think the market overall. And it drives trends down, and it drives waste out of the system. And today, we squeeze the balloon as much as we can to try and drive costs out of the system that are excessive. And what's left is we try and put the right drug in the right patient's hand for the right price and make sure they stay on that. So some of the challenges are, how do we keep people, like with that supply chain that you showed, how do we help people stay on the product once they get it, right? So everybody has access to products. Some may pay more than others, but how do we make sure that patients stay on those products? And that becomes the bigger challenge, I think.
Thoughts on the supply chain?
Well, I think the main problem we need to be talking about is how to make patients, make medicines affordable for patients, right? That's why we're all in business to begin with. And so I think there are a couple of key ways in which the supply chain system that we have affects patients. One is that patients are increasingly now faced with the list price, which is a fictional price and not the price that the end payer is paying. So That happens when they have a deductible. That happens when they have coinsurance. So I think that's a problem. It's made, of course, much worse when patients, because of the way we buy drugs, right? So patients buy it at the pharmacy and can't spread that payment out over time. And that's very unlike other kinds of healthcare services. So we're increasingly seeing all of the cost sharing for the year being squeezed into January, February. So that's another problem I think we need to address. That's it's a benefit problem, but I think that we don't need to be splicing this into supply chain and benefits. Like, the question is what works for patients. And clearly the situation we have now of, very high cost sharing in January, February, and then having that happen year after year for patients who have chronic conditions is not a workable system. And the reason is that we have benefit systems that were designed in the 1990s for a really different marketplace. And so I think it's sort of a bigger question than just the supply chain. I would argue that there are some beginning to be signs that there are some misaligned incentives in the supply chain broadly. I'll take one example. They're not here on the panel, but you mentioned non-retail. There clearly are some examples where hospitals are abusing market power and saying essentially, if you want our beds, take our inflated prices for cancer medicines. That's an example of a problem we ought to be able to focus on. And with regard to PBMs, I'd argue it's not so much the rebates, but all the fees that are imposed on pharmacies, specialty pharmacies, and manufacturers, which are sometimes also contributing to higher costs for employers and for patients. So I think there are challenges in the distribution chain, but what we need to keep our eye on the ball, which is what's happening for patients.
Matt?
I agree with Jenny on that. I think, but it comes back to a much more fundamental problem of broader affordability within the healthcare system, and drugs are certainly an important part of that and a growing part. And it's wonderful that we have these life-saving and life-changing therapies, but at the same time, when you look at the overall affordability, especially of newer drugs that are coming out to the marketplace, it's it's really eye-popping when you see some of the prices for new drugs coming out, and you go, well, that's a great therapy, but you know what? That's like the cost of a family premium. You could cover 4 families for one drug. And that's only like the cost of one drug, not the entire healthcare costs that these individuals face. And we really need to look at this balance overall. And I don't want to lose sight of that picture to start with, because it's not improving in that area. And I think we're all working to look at novel arrangements, value-based payments, et cetera. And a lot of the system has evolved. The drug world is still, I'd say, catching up significantly to the type of value-based arrangements that you see. And I know there are barriers and there are reasons why, and it's hard, but I also don't want people to believe that moving towards value-based payments for drugs is really going to solve our fundamental affordability problem. It's not. We're just not going to be able to do it across the entire spectrum of medicines. And then finally, if you think about this issue of rebates and high deductibles, and I experienced this with my own son the other day. We got a prescription, a topical dermatological agent, and the cost of the drug was $600 for one tube. And you go okay, well, let's say there was a pass-through rebate. Let's say it was 20%, right? And the list price was, say, $550, so you're taking $110 off. Would it have been that much more affordable if through a pass-through of the rebate, going from $600 to ballpark $500? I don't think that's really the issue here. We want to figure out ways to make the overall system much more affordable.
Lynn?
Well, carefully sticking to the question about what's most important, and because I know we're coming back to what are our proposed solutions, I'm delighted to know about the concerns with respect to patient affordability. That is the overriding concern here. Patients consume about 8% of consumers go to the hospital in any given year, and maybe 12 or 13% have an outpatient surgery. But 50% or more go and get prescription drugs, and they pay a high, on a percentage basis, there's more out-of-pocket costs for prescription drugs than there are for other medical services if you're insured. And so this is very, very top of mind for consumers, and it feels like prices are spiraling out of control for them, regardless of what some views of the aggregate data say. And I also want everyone in this audience to remember we have a lot of uninsured consumers, and they may be paying those invoice prices, and those invoice prices matter, and they are out of control. So I think that the most important thing is to look at every step of the supply chain and figure out where can we deliver better value to consumers, where can we make it more affordable. And I think we have to reduce the opaque nature of these transactions. I think maybe particularly with respect to PBMs, we've testified both in front of the Department of Labor and in front of Congress in terms of it's hard to know whether or not consumers are getting a good deal from PBM. So I'm not putting aside what those list prices for drugs. But most PBMs don't, in fact, have a fiduciary responsibility to payers, and then you have this opaque set of transactions where you don't really know what the rebates are or the pricing spreads. And I don't think that's serving us well. So I guess to wrap up, I think the overriding problems in the supply chain are looking every step of the way to see where we can get to greater affordability and greater transparency.
Thank you. Okay, as you know, the next question is about policy proposals, and Lynn, you can continue.
Oh, I was hoping, and I have to play off of what Neeraj said. In addition to being in the right order, we should have had an oversized pill bottle and an oversized dollar that we pass up and down. So Brookings and Schaeffer Center can keep that in mind for next time. So I think that there are a number of policy solutions we need to look at, and unfortunately, I don't really think competition is one of them. I think there may be areas of the pharmaceutical sector where that's going to help, but we have lots of evidence. There are a lot of natural monopolies in this sector. We have patient populations that are very small and really can't support more than one developer or manufacturer. We have government-granted monopolies that, as have already been described, and we have oligopolies. Look at the price of Gleevec and what happened to that when competitors were introduced into the market. The price of everything went up because they were higher priced than Gleevec. So, you know, there may be areas where competition is going to help us, but we had better not rely on competition to solve all our problems. I think the problem of having cost sharing front loaded is easily solved, and we should not spend any time on that. It can be distributed across the year quite easily with little effect on actuarial value. I think other solutions that we need to look at are, we need to get specific, like these aggregate analyses, again, are really useful from a framing device. But when it comes to how consumers experienced this sector, it is very specific to the type of drug they're trying to take. Is it Daraprim? Is it an EpiPen? Is it some drug where they actually are benefiting from competition and they're getting good value? Are they getting it from Costco? Are they getting it from CVS? It's extremely different depending on what the drug is, whether they're insured, and what type of retailer they're getting their drug from. We need to even out that experience so it's uniformly high value for everybody. And and this is actually, I think, one of the toughest policy problems because of the elements of natural monopoly that are there. So we can look at things like reimportation, which we support to a limited, to a certain degree. We can look at things like negotiating Medicare negotiations, but I think we're going to have to even look further at when those approaches don't drive drugs down to their proper value, and look at price regulation where needed. So I'll stop there, having stirred the pot.
Thanks, Lynn. Before I go on to Matt, I just wanted a follow-up question for you, Lynn. You were mentioning about that maybe competition doesn't have much potential. And I was thinking that, to the degree that you're going to engage consumers in competition, if it's a $50 drug, there's a lot of potential. If it's a $100,000 drug, probably very, very little potential. And I wonder if this trend towards the new, extremely expensive drugs is just actually making it a problem to use competitive tools.
I think that is a great question, but I I mean, I think like as with these programs to fill in the copay, we're just trying to leverage the insurer payment at the end of the day. You know, we're not going after consumers' house and things like that in order to pay for these drugs. We're trying to leverage an insurer's payment and get that into the hands of the supply chain all the way down the line. And consumers, this is very well established. When it comes to their health care, when they're in pain, when their quality of life is awful, they don't treat these things like a commodity. And if their doctor says, you need this one and not this one, and there's any way they can get to the one their doctor recommends, they're going to try to do it. I don't think there is a lot of potential to leverage consumer shopping in this space, and I actually think that's fairly common throughout the healthcare space.
Great. So I would agree with Lynn on some points. I would disagree a bit on the competition piece. When you are talking about orphans and ultra orphans, I think that you're right, that competition is probably not going to solve the problem, especially when you look at how with some orphans they're being used for much broader populations. But I would say that competition really does help, and to the extent that we can encourage competition and make sure that whether it's patent estates aren't being built up around products to protect them essentially indefinitely from competition, or other sort of ways that manufacturers are essentially trying to extend the market exclusivity period, competition can help in making sure that we get additional therapies on the market more quickly can be really, really helpful. We're also very focused, like Lynn is, on transparency, and we think that there are appropriate ways that we can protect the competitive marketplace, but have greater transparency and greater disclosure around what to expect with respect to launch prices, price increases, what's going around with inputs with pharmaceutical manufacturing. We know that there's a huge manufacturers. We know there's a huge disconnect between actual R&D expenses and pricing, and I think it'd be helpful to illuminate some of those. We don't want to get in the middle of proprietary contractual negotiations, because there's pretty good evidence out there that if you have that kind of price disclosure, it actually leads to higher prices, down the line. So we're focused on competition, on transparency, and also towards a greater move towards value. And if we can incorporate more value-based concepts, both within benefit design in terms of the economic relationships between manufacturers, plans, and other payers, it can be helpful. Again, I don't want to mislead anyone and say, that's the silver bullet, because there's so much talk about this move towards value, and yes, it's helpful, but it's not going to, I think, fundamentally change the affordability discussion we're having.
Let me interject something about transparency, because I've been focused a lot on that, usually outside of the pharmaceutical world, but that there are two audiences to think about for transparency. There's consumers making decisions, or physicians, or any person. There's also policymakers. And outside of prescription drugs, I've seen the real successes in transparency have not been giving consumers better information. It's been informing policymakers, large employers that make decisions, and we probably ought to make that distinction as we discuss transparency. I thought a lot of what Matt was suggesting really is to inform policymakers, which could be very useful.
So I think, again, if I was going to focus on what needs to be done, especially with regard to the kind of conversation we're having here today, I think we need to work on making sure that patients are benefiting from the negotiated discounts that are already in the system. I just say, I think it's a little crazy that when you go to see a physician or you have a hospitalization, that you get the benefit of your insurer's negotiated discount, and when you buy a medicine, you don't necessarily get that benefit. And so I don't think this is rocket science, and I think there are ways to do this that are not going to be disruptive of the market. It can be phased in gradually. It can be done thoughtfully. It doesn't have to be done in a one-size-fits-all way. But there are lots of, I just think it's common sense that patients ought to benefit from those discounts, and that it might not reduce every single patient's prescription, Matt, but it would reduce some of them quite substantially. And it's a violation, I think, of common fairness for patients to pay more than their insurer pays for the medicine. So I'd start there. And I do think that just stepping back, it's worth it to think about how to reduce frictional administrative costs in the system. AHIP's own data shows that we spend $1 out of $5 on the cost of insurance. That's more than we spend on prescription drugs. So I'd say if we want to think about how to reduce healthcare costs in this country, we could decide to cut into the new cancer treatments that are going to change the standard of care for patients who desperately need new hope. And we could do that even though the net spending on medicines is supposed to grow at 2 to 5% over the next 5 years. Or we could work on reducing administrative costs, maybe standardizing pre-authorization forms, looking at ways to bring HIT to revolutionize healthcare. That, if you ask me, would be a more productive place to go. So this discussion around the supply chain is a piece of that. How do we make the competition work in the way we distribute medicines, and can we focus on that because that doesn't have the same kind of risks to innovation that some of the other more draconian policies we've talked about do.
Yeah, Jenny, following up on the having consumers pay cost sharing based on real prices, is there a proposal that you and your colleagues think is workable?
I think, as I tried to suggest, there's not one proposal, but many ways that this could happen. I mean, we think that every insurance commissioner in the country could be thinking about what are the ways to make this work. Health plans could pass on average discounts. They could pass on across the whole plan. They could pass on discounts that are an average by the tier. They could work to the simplest thing is to move more toward copays, which show that patients were more likely to stay on their medicines in any case, because there's a lack of transparency when you have coinsurance. Patients they're afraid about what they're going to face at the pharmacy in terms of the cost. They don't have that information. That's transparency. We think that not the silver bullet, but useful for patients. They ought to know that. So shifting to copays, there are lots of ways that health plans can do this on their own or that regulators could encourage them to.
Yeah, a couple of angles here. One, I think in a way to bring about more competition, but also help the manufacturers, I think the length of time that pharma has to put in to create some of these new breakthrough drugs is remarkable. And the amount of effort that they spend recruiting patients and doing studies, and then however long it takes to get something through and get approved is a challenge, which drives up their costs, and the cost to bring a drug to market now is like $1 billion or something quite large. And so that leads to, how big is their market size and how do they, what do they price it? So I think if things got through quicker and got approved faster, would help the system, I think, and potentially drive more competition, which I think is healthy. Also, biosimilars and getting generics approved, in a more timely fashion helps the market, brings lower cost products to the marketplace. Ultimately, again, I'm getting back to competition, but all those dollars, when we either come out with lower cost products because the system is acting more efficient, will lead to, I think, hopefully lower costs for consumers. It should bring down costs for payers, which hopefully won't change benefits in a dramatic fashion, which is, I think, somewhat playing in this space of how much skin in the game does a patient have versus how much skin a payer has. And that, because prior to a couple of years ago, most patients had, or most benefits were a flat copay, and they've kind of evolved over time. And the pharmacy benefit was extremely rich. When most people were paying $25, $30, $100 for a prescription, when the cost might have been $400 or $500, it's pretty rich benefit that you were getting, and the supply chain was working to make sure that those benefits didn't change much. But for whatever reason, benefits have changed over time, and so that becomes now we're in this kind of challenge where we're worrying about how much the patient's paying for a product, which is concern. With that, and I don't know what could be done about it, but there are preventative drug lists also. So for maintenance drugs and things that are important, diabetes, insulin, things like that, if we could expand the preventative drug list, that allows, I think, plans to, and I'm not an expert in this space, but I think it allows plans to cover certain medications at like what a patient would pay after their copay is through. or after they're through their deductible, I'm sorry. So that's something, maybe that could be done as well. And then lastly, just, I know there are a lot of, pharma does provide a lot of copay, good or bad. Some people say copay cards are bad, but they do help consumers in a large fashion try to get through that. Now, whether coupons and copays are always as easy to get to, that's another topic. But anyway, I'll stop there, I think.
I was just going to go back to the question about value-based contracting, because I think that a lot of the conversation about that has been kind of narrow. And the way I would think about it is that we have a system right now which is all about chasing rebates and chasing discounts. And what we want to get to is a system in which payers are truly, the whole system is geared toward getting lower net costs, right, and getting better value. And the shift to new forms of contracting, I do believe, is part of the answer. So I do believe there's a lot of regulatory gridlock at the moment and barriers to the kind of flexibility that would allow manufacturers to work with PBMs, to work with insurers, to get to new types of contracts. And I believe that would actually change the terms of competition in ways that would lead to not just changing of the form of the price from it was the same discount, but now it's tied to a clinical value, but it's actually the level of the price would come down because you would find that there would be much more aggressive competition, especially in areas like oncology where there are a lot of challenges with offering treatments as part of a combination, and you want to be able to reduce the price for the third and fourth drug in that combination. So I think that there's actually quite a lot here, and that you would, despite the fact that there's tension on the panel at times, like you would find that there's a lot of agreement that the market and competition can actually improve things quite a bit if we can get some regulatory change to make it possible to contract in different ways than we have before.
Yeah, actually.
One quick
Oh, sure.
Sorry. I just wanted to mention one thing connected to what Jen was saying about making sure consumers don't pay more than the acquisition cost of the drug, which is that we can ungag pharmacists. And pharmacists are often under contractual arrangements where they cannot volunteer to a patient that's in front of them that they could get this other drug, or they could, not use their insurance and pay less for a given drug. They're not allowed to volunteer that information. So that's a low-hanging fruit thing that we could do.
That's right. I wanted to put in a clarification as a moderator, on value-based payments. I think there are many attractions of going that direction if we can, but when we talk about it, we shouldn't only talk about price decreases. Because if there's a drug that works in 20% of the patients, yes, it'd be great to have a price decrease for the 80% it doesn't work. But what about the 20% it does? Can't there be a price increase there? And isn't that what we would expect?
Well, yes, I guess in theory, but I think all of us would expect that the market is getting more and more competitive, and with the advent of biosimilars, I don't think that we're looking forward expecting that there are going to be large opportunities for price increases. The market actually works very, very well.
I'll just close with 2 points. One, if we had lower net prices for branded drugs to start with, we wouldn't be having all this value conversation because we wouldn't need to be having it. The second point around transparency, it's a little ironic that Jenny talks about greater transparency and administrative costs from health plans when we are in fact one of the few entities within the healthcare system that actually has regulatory oversight for the rates that you charge, and there's absolutely zero oversight for the prices charged by pharmaceutical companies. So I just close with that.
I'm going to let this session run a little later because I'd like to get some questions from the audience. Yes, and the woman in the red jacket, could you wait for a microphone, please? And say your affiliation and which panelist it's directed to.
Hi, thank you for this important panel. My name is Contessa Bourbon from the New York Times and London Times. I need panelists can answer this question. is there a legislation in Congress that can increase competition or can lead to price control? Who is the author, and what is your view on this legislation?
Yeah, I want to keep this, I'm sorry, but I want to keep this conference on distribution and competition. Next question. Yes, the gentleman, the short sleeve shirt back there.
Tom Timber, consultant. It's really for Professor Sood. Is there a source you can give us for how you pulled out the non-American factors in the SEC filings? Because particularly the manufacturers, a lot of their accounts are dominated by that. And of course, there may be reverse problems of non-American manufacturers who are don't have SEC filings. That's connected with as usual, the American supply chain is idiosyncratic. And the one thing you didn't mention is the role of the wholesalers' proprietary softwares in reducing the inventory risk, both for them and especially for the retailers. And I shouldn't say retailers, hospitals, all, if you will, intermediate level consumers. So I wonder, A, how you did that, and B, if you could address this role.
Sure. So you're right that a lot of the SEC statements, so for some firms, they split out US sales and global sales and report margins separately. For others, they don't. So this is a big picture view of what's going on. We did look at how gross margins are a function of the fraction of sales that are US, and they are an increasing function, but it wasn't a very strong positive correlation. So, like right now we report gross margins of 71% for all manufacturers. If you look at manufacturers which had very high US share, they probably go to 75%. So they're kind of in the same ballpark. So I think the bottom line is you should view my numbers not to the, they're not accurate to the exact dollars or cents. They give a big picture overview of what's going in these markets. And in some sense, the reason, like ideally, I'd like to do what Lynn was suggesting, which is follow a consumer who's actually buying a drug, then follow, the pharmacy, the wholesaler, follow all the people for that one particular transaction. But we don't have that data. That data is confidential. And in some sense, having that data or greater transparency would help policymakers kind of see who's taking exactly how much for what type of drugs, and then devise policy solutions. And I think at the same time, like as consumers, what Lynn said is that, we're not engaged in our drug purchases or in our healthcare purchases. And maybe that's the reason why there isn't price competition here, or the extent of price competition there should be. That if I as a consumer said, oh, there is a cheaper drug and I want to be on that because it will save me on my co-insurance, then that would lead to changes in the pricing dynamic. So I think some of the blame also goes to us as consumers, not just to people in the supply chain.
Just for a second. No. Well, I just want to remind everyone that, consumers have an incentive. If they feel that they're going to be equally well off between two drugs, they'll go for the cheaper one. The problem is it's very difficult to weigh an expensive drug with an uncertain outcome for that consumer and a less expensive drug with an uncertain outcome for that consumer. It's really impossible. And that's why we really have to look at the entire care team. And there is not a solution that puts that entire burden on the consumer.
This is a question for Dr. Sood and for the panelists. My name is Jeff Myers. I work for the Medicaid Health Plans of America. As you know, is it going now? As you know, 22% of Americans don't have any copay at all because they're in the Medicaid system. And that has a significant impact on the distribution of the way the rebates work through the system because the Medicaid drug rebate program. I want to know first, had you thought as you look through putting your data together, breaking out the way the Medicaid system works and the fact that 3/4 of Medicaid enrollees are in managed care, where states are either setting the formulary or giving it to the plans, and would that have affected your design? And then secondly, for the panelists, as you think about Medicaid now insuring 1 in 5 Americans, practically 1 in 4, and those Americans face no copay or $1 because it's a nominal amount except for Indiana. What does that mean for possible changes in terms of value-based purchasing arrangements or other ways to make the economics of the distribution system work a little bit better?
So I'll answer your first question, that we didn't look at Medicaid separately, and I think the picture would be very different for Medicaid. So I know like manufacturers would have lower margins on Medicaid because of Medicaid best pricing rules. Administrative cost of Medicaid might be different than private health insurance plans and so on. So we didn't look at that separately, and that's a valid point.
The panelists really had a lot to say. We've exceeded our time. I want you to thank them.